Well, also, I'd like to thank everyone for coming this evening. And what I would like to do is give some basic introduction to brain tumors in general, and then give some information about when we use radiation, some of the different types of radiation that we use, and really give maybe a little bit more understanding of what radiation is. Even people who've had radiation, I think most of them probably don't really understand what we do and how it works and why it works. So I'm going to try to cover a large area of material. So unfortunately, it doesn't address every issue in full detail. Any one of these topics could probably take a couple hours just to discuss in full detail. So it's sort of a broad overview, and certainly towards the end of the evening, we'd be happy to answer any questions. Can everyone hear me okay? Mm-hmm. All right, so just a little bit of background of brain tumors in general. And when we talk about brain tumors, we really need to break them down into two categories: primary brain tumors and metastatic lesions. And so primary brain tumors are tumors that really start in the brain and are created from the cells in the brain itself. And according to the National Cancer Institute in 2011, they estimate approximately just over 22,000 cases of these will be diagnosed. And then when we talk about brain metastases, these are cancers that have started in other areas of the body but have unfortunately spread to the brain. And these are many times more frequent. They're in the literature anywhere from 5 to up to 10 times more frequent. And it's estimated that anywhere from 20 to 40% of all cancer patients may develop brain metastases at some point during their treatment course or their illness. So when we talk about primary lesions, the vast majority of primary lesions are tumors called astrocytomas. And astrocytomas are tumors that develop of the glial cells. So these are actual components or cells of the brain that become abnormal and become a cancer. And astrocytomas are really broken down into different categories based on grade. And what grade of a tumor is that it's an indication of how aggressive we believe the tumor may behave. So there's grade 1, 2, 3, and 4. And grade 1 and 2 astrocytomas are considered low grade. Grade 3 and 4, grade 3 is considered anaplastic, and then grade 4 has its own category and is called glioblastoma multiforme. And grade 1 would be the least aggressive, and then as we go increase in grade, it becomes more aggressive, and grade 4 is the most aggressive. So astrocytomas are basically, as a group, over 80% of all primary brain tumors. There are some additional primary brain tumors seen here on the lower part of this slide, but these are really a very small percentage of what we see in daily treatment. We do see them occasionally, but these are the much more rare cases. Now, what are the symptoms that present when someone has a brain tumor? The most common symptoms are headaches, seizures, focal weakness. So when someone comes in and tells me they're just generally weak, that doesn't concern me nearly as much as when someone tells me they have right arm weakness only. And then some cognitive dysfunction. So that can be personality change, it can be changes in memory, inability to understand people, saying words that don't make sense. All those can be symptoms of these brain tumors. And why do brain tumors cause symptoms? Well, part of it can be that the tumor itself can invade into the brain tissue. But the other thing that can happen, and particularly with metastatic lesions, is that our brain sits in our skull and it's almost like a bank vault. There's no room for anything else other than the brain. And as something starts to grow inside that area, it puts pressure on the surrounding brain tissue. And that pressure irritates the brain and causes symptoms. So sometimes the symptoms aren't actually from invasion into the brain, but just this surrounding pressure pushing on the brain and causing these problems. So when someone presents with these symptoms, they often present to the emergency room. Usually a CAT scan is done first because often these symptoms can be similar to what happens when someone has a stroke. So we often will do a CAT scan, and once we determine there probably wasn't a stroke, we will do an MRI, and this will show us a lesion in the brain. The next question becomes, what do we do when we see that lesion? And depending on where the lesion is, how large it is, whether it's causing significant problems or not, the answer might be to surgically remove the lesion. The answer might be just to biopsy the lesion. And really that's a discussion that we have with the neurosurgeons, and they make a determination as to whether it's something that can be removed or just biopsied. And once we do that, we're able to establish a true diagnosis. And the other important thing with brain tumors is almost any patient that sees me wants to know what stage a cancer do I have. And brain tumors actually don't have a staging system. Almost all other types of cancer do have staging systems. And staging is a combination of the cancer in the primary site, whether or not it is spread to the lymph nodes in that area, and then whether or not it is spread to other parts of the body. Brain tumors are a little bit different because we don't have lymph nodes in our brain, so brain tumors don't spread to lymph nodes, and brain tumors rarely leave the brain. So we rarely see brain tumors spread to other parts of the body. It can happen, but it's extremely rare. So we don't have a staging system for brain tumors, primary brain tumors. And then other tumors, metastatic lesions that have spread to the brain, by definition are stage 4 because they've left the primary site and have gone to the brain. And then when we look at brain tumors, we also try to break down groups of prognostic indicators. And here, some of the most important issues are what the histology or grade of the lesion is. So when we go in, like I said before, with those astrocytomas, grade 1, grade 2, grade 3, grade 4, have an impact on prognosis. So ideally, a lower grade tumor is more favorable than a higher grade tumor, although thankfully we have much better treatments available even for high grade tumors than we did years ago. Other prognostic features are the age of the patient, as well as performance status, which really means how well is the patient doing overall in their life? Are they able to function normally? Can they work? Can they take care of themselves? Can they cook? Can they bathe themselves? Those types of issues. Their current neurologic status, so someone who has less symptoms often will do better than someone who has more symptoms. And then when we deal with metastatic disease, we look at the number of lesions often. So someone who has one lesion is in a more favorable prognosis than someone who has many lesions. Although what I have learned through my practice is even though we have guidelines for all this, real life doesn't always follow the rules. And we certainly always have patients that we, based on paper, might not think will do well, but ultimately do very well. We have other patients that we think will do well and don't do well. So I wouldn't say if someone falls into a poor prognostic group that means everything's terrible. It just means that we know we may need to take a little more aggressive approach to treating the patient.